I think we can just go ahead, whoever's getting onto Zoom. I want to especially thank all of the staff that helped make this possible. Mohammed is here with us from IT, and Emily Gokun did a lot of the work for the publication and moving things through and getting things set up for this presentation. And I'd like to introduce you all to Dr. Diana Ramos, who is our California Surgeon General. She has worked as an OBGYN doctor, so I feel the work that she did, as I'm also an OBGYN retired doctor, and she's moved on to more powerful positions, as you can see. And I will not bore you with anything more about that because she can tell you all about it. Dr. Ramos.
Thank you so much for the opportunity to speak to all of you. It is such a pleasure. And I'm going to be using the time to share a little bit about the work that my office is leading, and more importantly, how I have been able to insert my area of focus, which is women's health, into the statewide initiatives that my office is in statute to follow. So let's get started. Next slide, please. So these are the objectives, highlighting the fact that I want to make sure that the group knows about ACEs, adverse childhood experiences, then going on to share the work that is being done out of my office through Strong Start and Beyond, and then demonstrating how these two initiatives can actually improve lifelong health. Let's go on to the next slide, please. So I have no disclosures. And next slide. I want to get started with a case study. I know that your curriculum is very heavily based on case studies. And this is based on a patient that Dr. Vincent Folletti, who was the principal investigator for the Adverse Childhood Experiences study, shared with me. And the study, the pivotal studies were done back in 1991, 1995. And they were done out of Kaiser San Diego in conjunction and funding from the CDC. Dr. Folletti is a primary care physician. He's internal medicine as well as preventive medicine. And at the time, he was in charge of a weight loss clinic, a ketogenic clinic. So this is an example of a patient that would come in. And he has permission to share this patient, and he also gave me permission to share as well. But a 28-year-old who came in weighing 401 pounds. So Dr. Folletti shared that this was not uncommon. So he would share the patients would come in. This was about the average size of patients that they cared for. And they would undergo treatment, and about 51 weeks later, the patient would lose at 132 pounds. So they would lose over 200 pounds. But what would end up happening is that the patient would end up gaining the weight back again. And so he saw this happening over and over. And he asked, what's going on? He finally stopped one patient and he asked them, help me understand why you're gaining back the weight when you were doing so well. And it was at that point that the patient shared their story. And this is this patient's story. This patient was normal weight when she was 8 years old. You can see her there as a little girl. She loved to dance, was thin, was pretty. And the patient shared, when I was a little girl, I was sexually molested by my father. And he would say, you're so thin, you're so pretty. And she said, the only thing I can do to try to help myself was to eat. And it wasn't until I was gaining weight, it wasn't until I wasn't the thin person that he liked to abuse, that the sexual molestation stopped. And she went on to share that she had a younger sister and was encouraging her younger sister to also overeat because she didn't want her younger sister to also be sexually abused. So Dr. Folletti kept on trying to understand and ask questions and realized, and the patient shared, it was that weight that helped shield me, that helped protect me from all of the bad things that were happening to me as a child. She said, when I lost the weight as an adult, when I was down to 132 pounds, she said, now my boss was coming on to me sexually. He was now wanting to have sex with me. He was married. So she said, it was that weight that made me feel unseen that protected me. So this was the beginning of that ACEs study, the adverse childhood experiences, and the realization that what happens in childhood really does have an impact on our future perception of ourselves and really an impact on our health. Can I have the next slide, please? So this is a schematic of the big three categories of adverse childhood experiences: abuse, neglect, and household dysfunctions. You can see abuse can be physical, emotional, social. Neglect can also be physical or emotional. But the one that I really want to call your attention to is the household dysfunction. And the reason being is that this is a lot more common than what we realize. So what do I mean by that? Under household dysfunction falls divorce. So if the parents are divorced, that is an adverse childhood experience. If there's substance abuse, if one of the parents is drinking more, both of the parents, intimate partner violence, if somebody in the family is incarcerated or somebody in the family has mental illness. All of these are household dysfunctions that fall under the adverse childhood experience category. Now, the ACEs, to see how the severity of the adverse childhood experiences are assessed by 10 questions. And if you answer 4 or more yeses to those 10 questions, that is considered a toxic level of adverse childhood experiences. That is considered trauma, toxic stress. Next slide. You may be asking, well, how common is this? In California, 7 in 10 adults report at least one adverse childhood experience. In youth, 1 in 3 report at least one ACE. And one more click. The toxic level, the 4 or more, 1 in 5 adults express 4 or more ACEs. And then 1 in 25 youth are reporting 4 or more ACEs. So this is critically important because it's more common than what we imagine, right? I can tell you personally, growing up in South Central LA, single mom, a lot of violence in growing up, my ACE score was probably a 4 or more, so the toxic level. But you may be asking yourself, wait a minute, she is presenting before us, she's the California Surgeon General. What happened? I'm going to tell you what happened, and I'm going to share with you what we all can do to make it happen so that everyone has a more positive experience for the rest of their life. Next click, please. So adverse childhood experiences do not impact everyone equally. And you probably are seeing this already when you're learning about your other systems and the pathophysiology, the prevalence of disease, and you have probably now come to learn that there is a higher disproportionate rate of disease, negative outcomes in people of color. And sadly, with ACEs, we see the same thing. So the toxic level, the 4 or more ACEs, we see the highest level in American Indian, Alaska Native. Now, I want you to remember this because when you are learning about the prevalence of disease, you're going to notice that the Alaska Native American Indian population have typically worse outcomes and prevalence than the Black population. So keep that in mind. And this is what we see, the same thing here with ACEs. So the African American population was 26.4. And I do have to highlight that people who identified as being of 2 or more races were at 28.9. Hispanic were 24.3, very close to African American, but less. And then the average statewide is 20%. So the toxic level, the 4 or more ACEs, 1 in 5 people in California report having that toxic level of stress as a child. White population is 19.5 and the Asian was 9.6. Next slide. So again, highlighting the fact that not everyone is impacted equally by ACEs. Highlighting also that women low income, LGBTQ plus, and as we already saw, people of color are disproportionately impacted. And it's important to also keep in mind that discrimination is also included with racism as a risk factor for toxic stress. Next slide. So childhood toxic stress, you may be asking yourself, what's so bad about it? Well, it alters hormones, right? You've got the cortisol levels, you've got the fight and flight reactions, the sympathetic, parasympathetic systems. I hope it's now all starting to come together. I believe this is a second year class or many more, but now you're starting to see how all the pieces, impact health. So there is a change in hormones that causes inflammation, and that can cause and contributes to some of the most common causes of death. Number one being cardiac related causes. So what happens in childhood doesn't stay in childhood. It shapes biology, behaviors, and health across the lifespan. Let me show you. Next slide. So we know that if we address ACEs in childhood, so all of those 3 buckets of stress that we just saw, if we address that before age 18, now here is what we call an upstream, a preventive, a public health approach to health. You can prevent depressive disorders by 44%. You can prevent it. They never happen. The best depressive medication puts the average patient into remission, meaning that the depression goes away 50% of the time. You never need medication. You don't need the support. You don't need those, the medical visits. It's avoided. So addressing ACEs could be one of these solutions. Other areas of improvement are chronic obstructive pulmonary disease, asthma. I mean, you can look down the line, coronary heart disease, slight decrease in overweight and obesity. Next click, please. But the other thing that is improved and prevented is there is a preventive smoking decreases 33%, heavy drinking 24%. And there's an improvement in the social areas of health. So you may be asking yourself, like I did, like, how does this work? Because this sounds too good to be true. Well, if you stop to think about it, it starts to make sense. So what happens when we are stressed? What happens when bad things are happening to us? You want to control what you can. You want to change the way that you feel. And some of those ways of doing it are by drinking alcohol. You feel better, maybe temporarily, or you forget. You maybe use drugs, or you maybe just start to overeat. Use food as a way to feel better. So what happens is that if you have that stress continuously and your chosen way of feeling better is continued, it becomes a habit. And pretty soon that habit impacts your life. So what happens if you use food as a way to feel better? Well, then you're going to increase your risk eventually for high blood pressure, for diabetes, right? For all of those negative health outcomes related to obesity. What happens if you are over drinking? If you're over drinking, then you start to get into liver problems. You start to get increased problems socially. You can start to see the trajectory, how things just start to unravel in the negative direction when you focus and you are not addressing those adverse experiences that are happening. So I hope this is starting to make more sense and you realize this is a way for us to prevent all of these negative chronic health conditions that you are learning to care for. And this is what we call an upstream or preventive way of health. Next click. Now, I know that you are in the reproductive cycle or the reproductive system that you're learning about. So what about gynecologic conditions? And the way that I want you to frame this and understand it is that ACEs induce chronic stress, right? We talked about it, sympathetic, parasympathetic, that result in hormonal and immune imbalances. And that's why we see all of these conditions. So there is an increased risk for endometriosis, for hysterectomy, for bilateral oophorectomy. If you have more than 3 ACEs, you have a higher risk for a hysterectomy, severe menopausal symptoms, as well as chronic pelvic pain. Again, when I saw this, I thought, wow, I couldn't believe it. As a gynecologist, some of the most challenging patients that we care for are chronic pelvic pain patients. And until I learned about ACEs, I thought, well, maybe it is something physical that we haven't been able to diagnose, but maybe it really is some of the trauma that has happened early on, and we just haven't addressed that. Next slide. So other outcomes in terms of, I think go back one, I believe. Right there, reproductive health. There's a higher unintended pregnancy rates. So if you've got 5 or more ACEs, there's a higher odds ratio of an unintended pregnancy. Now you're maybe thinking, well, how could that be? Well, again, just start to think. What happens when you are under stress, you're under negative circumstances, you want to change the way that you feel. Maybe you're using drugs, drinking alcohol, taking risky behaviors, and you have an unintended pregnancy. And that goes along with a teen pregnancy, right? And sexually transmitted infections. So you can start to see the correlation of how all of these reproductive gynecologic outcomes are impacted by a higher ACEs experience. Next slide. The same thing is seen in pregnancy. So there's a higher, the higher the number of ACEs, and you can see that the higher the negative outcomes. So higher pregnancy loss, higher preterm birth, higher low birth weight. And again, you may be asking, well, how can that be? Why is it? So the association is, if you're not caring for yourself, if you are not making yourself a priority, and you maybe are obese, you have irregular periods, or you're drinking alcohol, or you're using drugs, you may not realize that you're having all of these risky behaviors that can increase to a pregnancy loss, that can increase to preterm birth, or that you're in denial of being pregnant and you may be getting prenatal care late. So that increases your risk for low birth weight, as lack of prenatal care is one of those risk factors. So that's how it all comes into play. I'm not saying that ACEs are the cure-all or the diagnosis of everything. I just want you to be aware of that there is an upstream approach. There's something that we may be able to do from the get-go, from the very beginning, when we do an annual exam with a person and look to see where we're starting from. And maybe, just maybe, there's support that we can provide them. Next slide.
Every journey toward parenthood starts long before pregnancy. It's about dreaming big, planning, and imagining the future. But what if your past experiences could shape that future in ways you haven't realized? Adverse childhood experiences, or ACEs, which include tough moments like family struggles, neglect, or difficult events, can affect our health even into adulthood. When a pregnant person has lived through ACEs, whether due to poor mental health, stress, tough experiences, or lack of support, the impact can ripple across each stage of their child's development. Unaddressed ACEs and untreated life adversity before and during pregnancy are linked to complications like preterm birth, low birth weight, poor nutrition, and difficulties bonding. These early challenges can create long-term consequences. But here's the inspiring news. The first vital sign of pediatrics is maternal health. Recognizing and dealing with ACEs early, especially before pregnancy, can dramatically transform you and your baby's future for the better. With the support of caring, trauma-informed healthcare providers, you can build resilience, gain tools to manage stress, and confidently step into your journey toward parenthood. Addressing ACEs early means breaking cycles of stress. It sets you up for success, helping you become the kind of parent you dream of being, and creating healthier, happier lives for your future children. This isn't just about changing your own life. It's about making waves of positivity that ripple through your family and community. With support, connection, and early care, parents can change the path forward. Let's make talking about ACEs a normal part of preparing for the future. Together, we can create a supportive environment that celebrates strength, resilience, and health. Every action today shapes the tomorrow we dream of. Address ACEs now and build a healthier, brighter future. Learn more at osg.ca.gov.
Thanks. Next slide, Muska. So this is a snippet from the Journal of Obstetrics and Gynecology. And the big conclusion, and just reinforces what we've been saying, is that when we address ACEs early on in pregnancy, in prenatal care, we are actually providing the resources that can make a difference in the mom and, more importantly, in the offspring, in the baby. So this is an opportunity. If there's anything I can leave you with, is just know that if we start talking about ACEs early on, you can make a difference in people's lives. Next slide. So I know if you're like me, and I kind of teased the solution, like how is it that somebody like me, who's probably has an ACE score of 4 or 5, maybe more, is here standing before you as California Surgeon General? And the answer is positive childhood experiences. So it really is, ACEs are a dose response. Okay, so what do we mean by that? The higher the ACEs, the higher the number of positive childhood experiences we need to provide. Positive childhood experiences counteract ACEs, and they help children feel loved, support, safe, and that strengthens resilience. Very important to remember. Next slide. This is a screenshot of what some of these positive childhood experiences are. And the positive childhood experiences don't only happen at home, where the child feels better when they have one caring adult to talk to, when they have support at home. It is critically important to have that support at school, whether it's a friend, whether it's a teacher, whether it's community involvement, church, sports, all of these positive relationships that reinforce the ability to talk to somebody, a trusted individual, makes a difference. Children just need one person to help them feel heard, to help them feel loved, and all of that starts to change their trajectory. And I can tell you, for me, that was my aunt. That was my tia. My tia would wait for me when I would get home from school, and she was a great baker. She would make some really good butter cookies and chocolate chip cookies, and she would sit me down and look at me and ask, "How was your day? Tell me about it." And that made a difference. We can all be that change, that support that every child needs. Next slide. So we talked about the prevalence of adverse childhood experiences by ethnicity, by race. But what about positive childhood experiences? So these are the good things, right? And I want to call to your attention the fact that the American Indian, Alaska Native group have the highest positive childhood experiences. Now, if you recall, they also have the highest negative, the highest ACEs, the adverse childhood experiences, but they also have the highest positive experiences. And you may be thinking, how can that be? Well, remember, this is a dose response type of thing. So the question that I would leave you with is how can we increase more of those positive experiences so that the ACEs that are bringing down the health outcomes of the Alaska Native American Indian population are counterbalanced. So imagine what the health outcomes would be if they didn't have as many positive childhood experiences. The other group that I want to highlight is the Hispanics. The Hispanic adults have the lowest prevalence of positive childhood experiences. So what does this mean? Well, the reality is that in California right now, we as Hispanics are 40% of the population. Now, if you remember all of the medical and social outcomes that are averted with addressing ACEs, if we don't avert it, we're going to get a lot more of those negative health outcomes. So it behooves us to try and promote positive childhood experiences with everyone. And I can share when I've listened to some of the focus groups from the Hispanic youth, they share, I guess I never thought about it, but when my mom, my dad, my grandmother, they call me gordo, they call me feo. They mean it with love, but it's not a very kind word. So gordo means fat, feo means ugly. They mean it with love. But now that I think about it, yeah, it does make me feel bad. So sometimes it's bringing awareness that, yes, that's something that maybe was done culturally, but then there are other more positive, more kind words that can be promoted and shared. And we can call our children those terms of endearment and not focus on the negative words. So that's just one small example. Next slide. So for those of you who are interested in learning more about ACEs, this is a QR code for a 2-hour training, CME for ACEs. And if for those who are in practice, if you complete the training and you have an NPI number and bill Medi-Cal, you can actually bill Medi-Cal $29 for doing an ACEs screening and talking to the patient about the results. So this is just to increase awareness and increase education if you want to learn more. Next slide. So this brings me to our other initiative. I shared that as an OBGYN, one of the areas of focus has been women's health. And I committed to reduce maternal mortality 50% by the end of this year. And also to help educate and empower individuals on their reproductive health. Because we hear it oftentimes that my doctor doesn't listen to me, my provider, nurse, whoever it is, they don't listen to me. So how can we change that? And that's something that we pulled together an advisory group. We heard what the recommendations could be, and we have initiated some of those programs, some of those outcomes that I'm hoping will make a difference. Next slide. So today is California, well, it's the United States Red Wear Awareness Day, highlighting the cardiovascular disease, the importance of cardiovascular disease in women's health. But more importantly, I want to share that in California, every 5 days, a mother loses her life to pregnancy-related complications. Every 5 days, a mother loses her life. That's unacceptable. Next slide. The reality is that 80% of the deaths are preventable. They didn't have to die. One more click. And this is how, again, it's important to always look at the race, ethnicity, what are the demographics, not look at the big number, but really look at the breakdown. And you can see that Black moms have been disproportionately dying more so than white moms. You can see here the total number of Black moms started out back in 2013, 2015 to be 58% higher than by proportion than the white population. Thankfully that we've brought that proportion down. but we have a lot of work to do. The other thing that I do want you to be aware of is that with the Hispanic moms, Hispanic women deliver 48% of the babies born in California, so almost half. And sadly, if we look at it by total number, the number of moms dying is slowly increasing. In fact, it's doubled if we look at the total number from 2013 to 2021, which is the latest data. But the other thing that I want folks to be aware of is that there's been a slight increase in the other ethnicities as well, from Asian moms to white moms as well, a slight increase in maternal deaths. So this is a red flag for us to make sure that we try to make the changes, improve the health of all moms in California. And it's not just the Black, yes, with an emphasis on Black, but we need to make sure that not one more mom dies. And just to make you aware, California does have the lowest maternal mortality rate in the country. But when we lose one mom, it's just one mom too many. Next slide. So data drives action, and this is something that you should always ask for. What are the numbers? How does this break down to help me understand? Because you can then determine your strategy on how you want to approach things. So when we looked at the data from 2013 to 2021, in California, the number one cause of death was heart disease. Heart disease for all races and all ethnicities. You can see that bleeding was 14%, hemorrhage, infection 12%, and the other is behavioral health. So behavioral health includes substance abuse as well as suicide, overdose. And the other thing to be aware of is that behavioral health, when we look at its impact on its association with heart disease, bleeding, and infection, there is also a co-association. So if we're going to start anywhere, we would need to start with heart disease, right? And cannot forget behavioral and mental health. Next slide. And that's exactly what we did. So we looked at the numbers and we looked at the timing of death. So when are we losing moms? Where is the biggest opportunity, right? You need to have a strategy. Where do we need to start? So if we look at the numbers of when moms are dying, you can see that 15% of moms are dying during pregnancy. 24% die the day after delivery. And then this is the shocker. 62% die after they leave the hospital. And you can see the breakdown up on top of there. 25% die on day 1 to 6, 7 to 24 days, 22% of the moms die. And after 6 weeks, 15% of the moms die. So they're pretty much outside of the healthcare setting when they are dying. Now, this is during pregnancy. We need to realize that there's an opportunity to make an impact before a person even becomes pregnant, right? This is a whole person care, and that's what we call preconception care. Next slide. So a quick case study, a 28-year-old Gravida 1, so the first pregnancy, she's 10 weeks pregnant. She has a history of a bipolar disorder, and one of the drugs that is used to treat bipolar disorder is lithium. And she has been on and off of it, and she didn't have any continuous care. So she is now presenting to you for her first prenatal care, and you counsel her that there's an increased risk for a heart defect because she was on lithium, and that's one of the side effects for lithium. And she said, I wish I would have known before I became pregnant that my medicine put me at higher risk for this. So people want to know, what can I do to prevent? What can I do in advance of becoming pregnant, right? That's not an easy situation for anyone to be in. So we took this into consideration and developed a resource for people. Next click, please. And we developed PRIMA, Preconception Medical Assessment. And we were deliberate in the name prima. Prima means cousin. And because remember, half of the births are to Hispanic women in California. So prima, it's a play on words. But basically, this is meant to be completed outside of the healthcare setting where people are not even thinking about pregnancy, but it gets them, once you answer the questions, you start to think about, well, maybe I should see a doctor. So it highlights, this is based and derived from a validated OB comorbidity index that assesses if a patient is going to be needing ICU admission or a C-section. So this has been validated. It's available in English, Spanish, other languages. But there are 8 questions with the goal to, yes, decrease maternal mortality, but to be able to start to think and talk to your provider of, I completed this quiz and it says that I may want to see a doctor because I may be needing more care. So there's general preconception information as well as the more yeses you answer, then the more direction that patients are given to the fact that they may need more care. And we had over 230 people validate this. And I hope my vision is that everybody, all of you who are listening, will complete it. This is so critically important to improve the health, your health now, your health of your patients before they're pregnant, before you're even thinking about pregnancy, so that you can take steps to improve your health. There's a focus on cardiovascular disease. Remember, cardiovascular disease was the #1 cause of death. There's a question on substance abuse as well, substance use, diabetes. So these are critical questions that can help make a difference. Next slide. The reality is, in California, 1 in 3 women of reproductive age have at least one chronic condition. So this is the preconception piece. And the other fact is that in California, 1 in 3 pregnancies is unplanned, unintended. So if you happen to have a medical condition, you happen to be taking medication that could be teratogenic, this is the time that you want to be sure that you know, what do I need to do to prepare for a pregnancy in the event that I want to get pregnant? Next slide. Now we're going to be moving on to pregnancy. So important to highlight how prenatal care can make a difference in a pregnancy. Yes, it's ideal to start before pregnancy, preconception, but to realize that with no prenatal care, there's a 3 to 4 times more likely, the higher likelihood of to die from pregnancy complications. This is in the patient, and 3 times more likely to have an infant death. So the impact is big. Oftentimes, remember, 1 in 3 people reproductive age have a chronic medical condition. So all of those conditions can impact their health during pregnancy and the baby as well. Next slide. I talked about heart disease today being Wear Red Day, and how cardiovascular disease is the #1 cause of death for all ethnicities up to 1 year postpartum in California. The reality is that cardiovascular disease is the #1 killer of men and women in the United States overall. So in pregnancy specifically, why? What's happening? Well, we're waiting more longer time to have a baby, advanced maternal age. Oftentimes there's hypertension, diabetes, obesity, and congenital heart disease. So all of these things contribute to cardiovascular risk factors. And you can see here how the number of hypertension of people who delivered in California breaks down. You can see in the map too how it's all mapped out where in California the highest rates of hypertension are, and then diabetes as well on the right. Next slide. In terms of cardiovascular disease, when you this is another big takeaway. If you're going to walk away with something, Do not forget that cardiovascular disease is the #1 cause of death for women too. All right. Just because they're not a man does not mean that they don't have a risk factor for heart disease. This is from a publication that Dr. Afshan Hamid published, was the lead author, and this is on heart disease. The reality is most people who died from cardiac conditions during pregnancy or postpartum were not diagnosed before death. The diagnosis was missed. They had underlying risk factors and they had presented with signs and symptoms of suggestive of cardiac disease. So what are those? It's swelling, it's headache, it's maybe elevated blood pressure. I'm not sure if you've learned already about preeclampsia, but blood pressure greater than 140/90 in pregnancy, you've got to rule them out for preeclampsia, for gestational hypertension. 140/90. If you were to take that number in somebody that was not pregnant, that's not an alert. But in somebody that is pregnant, that's a red flag. Okay, I need to do more. And more than 80% of all pregnancy-related cardiovascular deaths, regardless of the cause, were preventable. So the onus is on us. Yes, it is on us to listen to our patients when they're coming in. Next time when you're on your OBGYN, your OB rotation, and you hear a patient, they're saying, I have a headache, my feet are swollen, stop and remember this slide, please. Because you may have a patient that has underlying cardiovascular disease, and do not dismiss them. Look at that blood pressure, sit down and listen to the patient. Next slide. The other area that I want to highlight and focus on, we talked about it, behavioral health, and how that was also an elevated cause of maternal deaths, and it corresponds with other medical conditions. We have to remember that under the adverse childhood experiences bucket, that was one of those household challenges, right? That if somebody at home had a mental health conditions. So maternal mental health can be an ACE. What the mom feels, truly the baby also feels as well. We have to keep that in mind and not overlook the fact that they're independent bodies. Well, the impact is they're impacting each other. The stress cortisol, the intimate partner violence, if it's present during pregnancy, all of that increases the cortisol level in the baby, and it just dysregulates the development of that baby. Next slide. So maternal mental health, 1 in 5 mothers are impacted by mental health condition. And the other thing to look at is that maternal mental health is the most common complication of pregnancy and birth that affects over 800 families each year. This is not even related to maternal death. This is just in general. Most women are untreated and are at increased risk of negative impacts, over 75%. So we need to make sure that we are looking at mom, do the depression screening, and listening to mom. Next slide. We know that the impact of maternal depression on a child can not only interrupt her prenatal care, but her ability to care for that child. If you're not taking care of yourself, if you don't care about yourself, you're pregnant and now you have a newborn, you don't have the energy, you don't have the wherewithal to be able to care for somebody else. And so the consequences on the baby that we oftentimes see is a delayed care in preventive well child visits. There is developmental delay. There is also difficulty with bonding. And then that goes on with the child as well. They have a harder time bonding and developing relationships when they grow up. So it really is a ripple effect. When we improve the health of mom, we're improving her health, we're improving the baby's health. And we have to remember that there are more people in the family. It's everybody else in the family that is impacted. Next slide. So to that response, we have launched a campaign, and I'm asking all of you. I know sometimes classes will do a class project day of service. I know at USC, my alma mater, we're doing a day of service coming up next month. I encourage you to do this as your day of service, one small thing. So postpartum is oftentimes a time of isolation when we don't have the support that we need. From data, 62% remember of the maternal deaths occur after hospital discharge. 42% of new moms report severe loneliness or isolation. And loneliness is the strongest medical predictor of postpartum depression. So that's why we launched the One Small Thing campaign, where we are encouraging people to do one small thing for a new mom, from babysitting for an hour to taking her to the doctor, bringing food, just checking in on her, being the eyes and ears in her life. And you could see, wow, her feet are swollen, or that headache that you've been complaining about, it's not going away. Let's get you to a doctor. If we bring back community, we can really help save a life. Something very simple. In California, we have 40 million people. That is our population, and we only have about 400,000 births. Imagine the power of care, the power of prevention, if every single person did one small things for those 400,000 new moms. All right. So I am challenging you. I am asking you, partner with us on one small thing. The QR code is there. We have some great coupon books that you can give at baby showers. And if even patients, I know many clinics will have baby showers for their patients. And the coupon books are here. Use this coupon for the food. Use this coupon for an hour so that you can take a shower and just take a nap. Little things make a big difference. Next slide. And other things too that we developed out of my office. This is for family members, friends who are in the lives of a new mom. Many times and you'll be in clinic and you'll see that you'll tell mom what the signs and symptoms are of depression. But what ends up happening is that people are at home, and the people at home don't know what to look for. And this is just a quick little infographic on what you need to look for. Look for changes in behavior. They're not combing their hair. They're not getting out of bed. Listen for harmful words. I want to kill myself. I'm a terrible parent. Provide words of support. One kind word makes a huge difference, and really direct people to the support that they need. And the QR code there directs you to support and places of maternal mental health programs as well. That are provided by our public health sister agency. Next slide. And yes, there is a 988 number for suicide and crisis lifeline. And this is a toll-free number on the right. That is a maternal mental health line. If you call 988 and you are pregnant, they will transfer you over to the maternal mental health line. But know the number is 988. Next slide. And just to leave you with the realization that pregnancy is a window to future health. What do we mean by that? And keep this in mind. High blood pressure in pregnancy, there's a 63% increased risk of future cardiovascular disease. So the patients that had preeclampsia, the patients that had maybe severe preeclampsia, they have over a 63% chance of future heart disease. So you need to make the patient aware. You need to make sure that you follow up with your postpartum care, that you follow up with your annual health visits, and let them know that you had high blood pressure in pregnancy so they can keep an eye on it. Many times people think, oh, I delivered the baby, my blood pressure's gone, I'm cured, I don't have to worry about it. Quite the contrary, they had a sneak peek to the potential of heart disease in the future for them. Same thing with diabetes. There's a 20 to 50% chance of developing type 2 diabetes later in life. And then the reality is that suicide has increased with those with depression. So keep this in mind. Just because you deliver the baby and it appears that these have resolved, quite the contrary. Next slide. So I want to leave you with a call to action and just to make you aware that you are part of public health leadership. Thank you. Thank you for being in medical school. It is not easy. It is a big time commitment, but you are entering and you are becoming part of the really, it is a coveted profession to be part of the lives of people, to be able to help prevent disease. Public health is prevention. I really thank you. And I cannot emphasize enough the reminder that mental health is foundational to health, right? I hope I've shown that to you by focusing on the mom and then beyond. And the trauma that we've talked about, the ACEs, it is preventable and it can be resolved, counteracted with positive childhood experiences. And prevention is powerful medicine. Yes, it is medicine. So healthier lifestyles and being supportive of our patients is so key. So thank you for being an essential part of California's future. Next slide.
We get the PRIMA questionnaires.
Yeah, primaca.gov, and Muska, maybe you can put it in the chat as well. So please, so one of our initiatives is to promote Prima, and I heard a great idea. I thought I love it. To be able to share for people who have baby showers, for people who are getting married, who are even on a girls' night out as a game, complete Prima, complete Prima, and you make it a conversation starter amongst yourself. It's really is, it can make a difference in somebody's life. But primaca.gov is the site. I'm reading in the chat, there's a question about toolkits for Prima. Please go on our website. There is a toolkit for distribution. We even have a widget. So you can download the widget so it can be virtual. Would love it if it's on your, I'm not sure if you're